Hey everyone, here's a really brief overview of the issues around CVCs in the emergency department. So if we think about it, there are fewer indications these days for actually putting a central line in the ED. We have alternative means of getting vascular access in terms of using ultrasound for peripheral IVs or putting intraosseous in a resuscitation situation. For noradrenaline and other vasoactive drugs, we have a policy that allows us to start those drugs through a good peripheral line. So there's no urgency in a septic shock patient to put a central line in. And plus, most of the time, we have a pretty accessible ICU who are often happy to take patients prior to CVC insertion in certain circumstances. So we're doing fewer of them. There's also the perception that if a line is put in the ED, it's just not as good as if it's been put in theatre or ICU. This concept that an ED line is a dirty line, and the view by some intensivists, traditionally at least, that all CVCs put in the ED should be replaced when the patient gets to ICU. This is obviously not ideal for a patient who's then subjected to a second procedure, potentially unnecessarily. So the idea of our approach to central lines is to minimize the risk of complications, which include infective complications, mechanical complications like pneumothorax, and thromboembolic complications, including the embolism of the guide wire if that's left in. Now, the challenge we have is that at Northern Beaches Hospital, the only required documentation, if you follow the written policy, is that of the ANZICS checklist, which is very good, but is all about preventing line-associated septic complications. So it's all about the asepsis and the preparation for that. It is quite possible to get full marks on this checklist and yet to inadvertently puncture the carotid artery, cannulate the carotid artery, create a pneumothorax, and leave the guide wire in the patient. This checklist would not protect against any of that situation. And in fact, in our ED, we have had some complications that would not have been picked up by this checklist. The New South Wales CVC insertion record, which you may remember from Manly or Mona Vale or from other places you work, is much more comprehensive and much more fit for purpose. And in order to include the stuff on this and the ANZICS stuff, a combination has been made by Bridget Macy, our resus nurse, which has just been reformatted into this checklist here. So this is the checklist I propose we start with. We can always modify it based on feedback. And on the reverse side of the checklist, there's guidance on insertion depth, depending on which vessel you're puncturing, and a place for additional comments, which will then be filed away in a folder in Resus for follow-up. So although the checklist is very comprehensive and might appear like a recipe, that's semi-deliberate because we're not doing this very often, and different staff specialists and registrars will have different levels of experience and comfort and may not have done one for a good while. So it's really to protect ourselves and our patients and act as an aid memoir. Now, a checklist is not training. It doesn't replace training, and certainly for our intensive care team in the hospital, their system is to do the online Clinical Excellence Commission training by watching these videos, and then have some supervised lines, seeing lines and then doing lines under supervision, a certain number at each site. I don't propose that we undergo exactly the same training and accreditation method that they do, because there needs to be some recognition of prior learning at other emergency departments and other spheres in which we work. But I do think it's a good idea to watch these videos. Now, you can go to the website and you can click on the videos, and all of the videos together take about just over 40 minutes. But if you click on this settings cogwheel in YouTube, you can alter the playback speed and watch it at double speed. There is no audio with these videos, it's just reading these presentations. So you can read at your own speed by clicking through or by playing it at double speed. So it should definitely not take you 40 minutes to go through all of the videos. There is a quiz at the end, and I do recommend that everybody does the quiz, and the CE site suggests taking a photo of the part of the video that says you've completed the quiz. But what we will have is that quiz reproduced on our Articulate Rise virtual learning environment, so we can actually provide evidence that we've done the quiz. So there will be a very brief VLE in the style of the Josh Holden ultrasound training, with an overview of our approach, links to those videos, and that quiz that we can do and provide documented evidence that we've done it. If you can bear with me and help with the checklist, I'm more than happy to modify it based on feedback when we have some experience with it. But what we lack at the moment is any governance regarding central lines. That has to change, and this is a proposed system that's as painless as possible, that recognises prior learning, gets the Clinical Excellence Commission quiz completion tick box signed off, and has an aid memoir that doubles as a checklist, that doubles as an insertion record for audit purposes, and that's the way I'd like us to go until we've reviewed it. Send me your robust and constructive feedback, which I will endeavour to act on. Thanks very much.